Good afternoon. Thank you for joining us for the webinar, Modern Radiation Therapy for the Treatment of Non-Melanoma Skin Cancer. This webinar forms part of the Rural Health West 2020 virtual conference. Before I hand you over to your presenter, I'd like to run through some brief housekeeping. If your audio is not coming through, you may wish to switch to your phone. These numbers will be listed on your dashboard. Remember to enter the PIN number 2. Everybody has been placed on mute to minimize background noise, but we would still love to hear from you. Please enter any questions into the question box, which you can see on your dashboard. These will be answered at the end of the presentation. This session will be recorded and uploaded to the Rural Health West website under the virtual conference banner. I'll now hand you over to your presenter, Dr. Kasri Rahim.
So yeah, my name is Kasri Rahim. Thanks again for the opportunity, and thank you to the Rural Health West for the opportunity to talk about skin cancer, being non-melanoma, and the use of modern radiation treatment for treatment. So what we're going to go through today is just a bit of disclosure, and there's nothing conflict of interest today. So there's a few things I'm going to go through today. First one is actually about the modern radiation therapy, and some of you might have heard this already, about the advancement of the technique that we use in radiation treatment, and the place for radiation therapy in the treatment for non-melanoma skin cancer, and also what do we do now is actually that we're able to treat a wider area of skin for sort of wide field changes, including situ disease, and obviously the use of radiation in conjunction with surgery. So we're going to go through a few of these together for the next 20 to 30 minutes or so, and we'll take some questions right at the end. So modern radiation therapy, what has changed over the last 100 years actually, when radiation was first discovered. But first of all, this is actually a bit of an overview to what we've done in Genesis Care, where prior to 2016 we were just using the older technique to treat skin cancer, and now things have changed a lot with the invention or the birth of National Dermatology Radiation Oncology Registry. It started off in Australia, in South Australia, and from then on we started off with these Project Spot, which is something that we're going to talk about in a bit more details in a minute. And moving forward, we've done over 2 years of this now. I haven't quite got the full updates of the whole registry, but I have some sort of key points to actually share with you guys, the audience today. So some of you might have seen these sort of pictures from the past, where people were being treated for skin cancer in Europe, and the treatment that were done at the time were going over a period of between 9 months to about 30 months. And obviously back then the radiation that were used were in different forms. Most of them would probably use a radioactive source, such as radium surface brachytherapy, and also the much older forms of radiation machines. And likely we're not actually using any of those today to actually do this treatment for our patients. So what do we have today? So this is the kind of machines that I have now. Let's say in this center where I work now in Mahendra, and we've got this sort of a machine called Versa HD. It's probably one of the best machines that is actually being produced by this vendor. And to your right hand side there, this is actually what we call a superficial machine for treating skin cancer. We still have this unit available at Fiona Stanley Hospital, being used for treating some simple skin cancer. Probably be included in this topic that we're talking about today as well. So these are the two machines, one of the examples of machines that we have now, and clearly it's different than what we have shown you previously. So previously, prior to 1950, back in the days, radiation was all about blocks. We're treating radiation any parts of the body. It has to be in a square or rectangular shape, and that's actually why people would actually be getting radiation too. So treating either a big field or treating everything that's in the field, and then starting from probably about 1960, we started saying, hey, you can't just do that. Let's just focus radiation to a certain shape or parts of the body. And then the invention of CT scanner back in the 80s, and then the use of that in radiation planning in 1990s has allowed us to use what we call 3D, three-dimensional conformal radiotherapy, where we can actually shape the radiation field to follow a certain organs or area of the body where we can actually treat, and then while sparing some of the other organs that we don't need to treat. In 2000, we started doing what we call IMRT. This is actually more like treating, to almost the precise shape of that organ. Let's say, being this model here, we actually treat that shape alone without treating any other parts of the body. And then moving forward in 2010, we started doing what we call dose painting with VMAT for treating an area, just part of the body, while sparing things in between. We can actually have a circle shape sort of radiation, and we can actually spare something in the middle. This is actually something doable with VMAT. And the treatment time, obviously, from 1960s to 2010 has actually improved significantly with VMAT. Now we're talking about treatment time just down to about a minute or less. Whereas back in the days when we were doing IMRT, it might take about 10 minutes, and prior to that, it's a lot longer. So we're talking about much faster treatment, can be delivered in a shorter time, and also fairly precise and fairly conformal to the area of treatment. And now we're talking about VMAT for extended skin field treatment for treating, like for example, in this example that you're saying there, there's actually treating a strip of skin over the leg, while actually sparing the deeper components of the muscles and bones within that legs. And that's actually another example that we're going to go through today, that hopefully you might be able to appreciate the advancement in technology in radiation treatment for skin cancer. So I'm hoping that, Kate, we might be able to play this video. If you can't sort of see it, please let me know, and then I will just move my screen across to this monitor. So this is actually, you can see that, Kate?
Yes, we can see that. Yeah.
Yeah. So this is actually a YouTube video, obviously. I just want to show you what VMAT is all about versus the conventional radiation. And at the bottom, you can actually see the times taken to deliver the treatment. All right. So I'm just going to play the video. It lasts about 30 seconds. I don't think we have any music to go with this. So just bear with me. I'm just going to talk you through. So this is actually a treatment, not a skin cancer, but there's actually a head and neck treatment. On the right is a VMAT, the new technique, and then on the left is actually a conventional 3D conformal treatment, or IMRT. So VMAT only took about 5 seconds there, and even with IMRT, you're still going and still going and still going. So this is actually the advancement of VMAT. It allows the treatment to do the same thing that we want to achieve, and at the same time sparing the organ at risk in between the treatment fields. And just another view here, just to show you how we achieve that. Just a quick video again. I'm just going to make that a little bit less in terms of the sound there. So in this machine now, we have this thing called multi-leaf collimators. And these are parts of the machine that is responsible to shape the radiation field. And these MLCs, could be about 200 of them, will actually move at the same time as the beam is actually being on during the treatment. And the patient will actually just lie down having the radiation treatment. The machine will move around the patient, deliver the radiation treatment to whatever shape that we actually have already pre-outlined, or we pre-planned prior to patient coming in for the treatment. And this is actually what we talk about, being VMAT that I've already mentioned just now. So I just want to show you that part of the machines to how we are able to achieve this. And this is actually a similar example to what I've already shown you already. And this is when we can shape it to anything that we like, any parts of the body. You can see the sparing of the spinal cord in this video. You can see the sparing of the parotid glands, higher dose in some areas, lower dose in blue in some area. And this is the kind of thing that we want to be offering our patients these days. Now, I might just swap over to my other screen before to go back to where we were, if I may. So that's actually a little bit about VMAT. It stands for volumetric modulated art therapy. So the next thing is, so the next part of the treatment is about when do we use radiation treatments when surgery might not be feasible. So I'll give you a few examples today, and we're going to go through some questions at the end, and feel free to ask those questions. I'll just give you an example here. This patient had a basal cell carcinoma biopsy proven at the creases just above the nasal airline on the right hand side there. She could have surgery for this. We do see a lot of these patients having had one or two surgeries, and the problems with the BCC, some of them will actually be coming back with either perineural spread or maybe closed margins. So instead of using surgery up front, the patient was given the consideration of radiotherapy to perhaps avoid rotational flap or skin graft and have the similar outcomes. So patient was treated with a dose of about 55 gray delivered over 5 weeks. And you can see the difference between, at the beginning of the treatment there on the left of your screen, and obviously after 3 months in the middle, and what happens after about 15 months. So we actually see a complete response to the cancer in that area with a good cosmetic outcomes in the end. So these are the sort of areas sometimes we would actually prefer patients to be given consideration for surgery on the face, around the inner canthus of the eyes, for example, on the ear, where it might not be as straightforward to just do surgery up front. But I know that there might be plastic surgeons in the audience, or that you might be aware of already. That sometimes with a certain surgical skill, you might be able to achieve that. But this is something that we would consider treating with upfront radiation treatment. Another example of my own patient, she had a skin cancer, also a BCC. The skin cancer, if you can see my pointer moving here, it actually was originally started about there. This is actually a picture taken after the treatment, probably about a year after radiation. I don't have a picture of her prior to radiation, unfortunately, to show you today. But this is the sort of thing that we'll be able to do now with a VMAT, where we would actually treat the area of concern being the front of the nose, at the tip and the bridge of the nose. And with VMAT, we're actually able to curve the radiation treatment to spare the septum of the nose. Previously, this is what we were doing, whereas now we're able to do this. And believe it or not, I think that's actually helped to preserve the cartilage in the septum, and in the long term, less worries to the patient in terms of complication and the late effects on the cartilage of the septum itself, whilst getting rid of the skin cancer, give good local control altogether. So that's an example on the nose. Obviously, we have examples, people have skin cancer in different parts of the body where we might not be able to offer do surgery with a good clearance up front, and radiation can be considered. This is going to be a bit more interesting to the topic that we're talking about today, where we want to give you an example here. The case number 2, very common, a lot of is here in Australia, especially the farmers, or just in general in public. And we've been out in the sun, not wearing hats, to get this extensive sun damage on the skin, including the scalp, where they might develop a lot of extensive intraepidermal carcinomas or Bowen's disease. a lot of in situ disease where surgery, which might actually has been taken, might actually have been done here for him in the past, and also some radiation previously. In the past, we were not able to treat, in an area of this size with our older technique, but it's now in this example here, we can use VMAT to just treat the surface of the scalp. You can see what the skin looks like prior to radiation on the left, and then at 3 months after radiation, once the skin has reaction has healed, and at 12 months to how the skin might look like after for this gentleman. He did have an ulcer, a small one. You can probably see that. I think that's about there. And also, sort of tight feeling from the scar tissue of the scalp, but obviously cosmetically and also for the oncological outcomes being the extensive SCC in situ, you can see the good response from a radiation dose using VMAT over 5 weeks altogether. Another example here, actually is a patient of a scalp or forehead there, and I also had the same sort of similar problem, multiple areas too big for multiple operations being sent over for radiation. In the old days, we would have used, what we call electron therapy for this big field. You can see the limitation there. Cannot treat such a big area, although it looks big already. Whereas now we can actually cover a much bigger area with VMAT while sparing the brain, obviously, and obviously you can see this the difference between the area of the appearance of the skin prior to radiation and after 5 weeks of radiation. This is the sort of thing that you might see in the patients, noting that he might have lost a few hairs actually in the area, and these are the sort of thing that would be discussed at the end about hair loss. We will go through that in a bit more details at the end. So another example there to how we can use VMAT these days, and obviously we'll be doing a lot more of this since we started doing this over 2 years ago. Another good example, someone with a lot of skin damage in the on the forearm there. Obviously, extensive damages, probably not suitable for just surgery alone, and has had a lot of skin cancer removed from over the years. Have used some topical cream, used diatomy, 5-FU, acitrenin, and cortisone, and obviously been referred for consideration of radiotherapy. He obviously was deemed to be a good, suitable candidate for this treatment over 5 weeks. And at 3 months, you see the difference between on the left and in the middle, how all those changes of the skin cancer and also SCC in situ sort of disappearing over that length of follow-up. And then after 12 months, you see that the skin is becoming less tight and less sort of changes, and then more sort of fairly clean from any of these solar keratosis or SCC in situ. I think it was reported they did have one isolated actinic keratosis on the skin, which probably can be managed, with a topical sort of treatment. So that's another example of the arm. This is my own patient, I actually saw him not that long ago. I've treated him. He was a retired roofer, so he used to spend a lot of time on the roof, wearing shorts. I have got a few pictures there. Focus on the right hand side, sorry, left hand side of your screen. This was actually his right leg that I treated last year. So this sort of treatment that I was trying to show you before, where previously we wouldn't have been able to actually spare the bones, the muscles, and the inner part of his scalp muscles there with the older forms radiation treatment. Whereas now you can actually skim through the surface there, and his leg, 6 months. It was actually taken at the beginning of this year. That's how it looks like after the radiation over 5 weeks. And on the right-hand side of your screen, this is actually a picture of his left leg before he started treatment at the beginning of the year. That's how it would have looked like on the other side that we of his other limb. I could not take any updated pictures for him because of the COVID-19. He's only had a telephone consult with me the other day, but you can actually appreciate that this is sort of response. I would actually see the difference between of the changes on the skin prior to radiation and at 6 months on the leg. It looks so different, and the patient's very happy not having to have any more sort of intervention done. You just need to follow up through for the over the years, hopefully. And another example is actually, I haven't got much details on his radiation field today. This is actually a freshly taken pictures from yesterday. I saw him yesterday just before this talk. I called him back to show to share with you about this gentleman from further south. He has had about 40 cuts or 40 excision done to the skin clinic over the years. You can see the scar on various parts of his face there, and also multiple skin graft. So he was referred to me for incompletely excised SCC on the right temple area. So we started, I explained to him the options of VMATs or this technique called sport to him. He became very interested. We ended up treating his right temple, right cheek, and the scalp in the first attempt, and excluding that skin graft that was treated. You can see on the left, and this is actually the picture that was taken yesterday on the right hand side of the screen. The picture on the left hand side there was actually taken about 6 months ago, prior to him having radiation to his left cheek, left temple, and all this sort of keratosis and the redness that you see there. That was actually at least 6 months ago. He had a 5 weeks radiation treatment, and then now you see the picture on the right hand side of your screen. The difference between what was like prior to radiation and what it is like now. He's a very happy gentleman now. He's still got most of his hair. Mind you, he probably noticed that he might have lost a few eyebrows, which probably from the radiation treatment, which we'll be talking about in more details at the end. And this is sort of a treatment that I'm hoping to offer more patients should they become suitable for our sort of advanced treatment. And obviously, this gentleman has got a few other parts of the body that will actually need radiation treatment. I'm happy, yesterday we talked about the possibility of treating his arm, and obviously, if you have the opportunity to share some of the results later, obviously, I'll be able to update you on what happened to his limbs, because that's the next part of the body that he wants to have treatment to. So that's another example there on the wide field, treating the forehead, the scalp, the face really, except that we haven't treated his nose. You can actually see in the area near the nose there, there's a little sort of early changes. Could be just NCC in situ right there, because that actually has not been treated with radiation treatment at this stage. So the next part of the talk is actually the radiation therapy. How do we use that in conjunction with surgery or local excision? I'm just going to show you the indications, because I think we probably have seen enough photos there. So these are the tables summarizing all the reasons to why we might consider radiation treatment on top of doing surgery, either by a general practitioner, dermatologist, or plastic surgeons. Absolute indication, obviously, is a big tick disease involving the deeper structures, T4, positive margins, perineural invasion, or recurrent disease. We definitely want to see them to consider radiation treatment. For the positive margins, if it's in the area that could actually be re-excised, that could actually be the first consideration when patient comes into clinic. Other indication could be, sort of not too thick, but thicker than just a superficial cancer, so being T2 or 3, or being deep, being about 4 millimeter, close rate, surgical margins less than 2 millimeter, high grade cancer, fully differentiated SCC, for example, Perineural invasion within the microscopic or the pathological report, lymphovascular invasion, patient being immunosuppressed because of other conditions, and high-risk sites such as earlobe or lips, where they are more likely to metastasize or spread to the other parts of the body, being the lymph nodes usually. These are the ones that we probably want to consider adjuvant radiotherapy for. Those are for the skin lesions that's actually being excised locally, and obviously for patient with nodal disease, might be in the head and neck area, axilla or groin, we would consider doing that for these indications. We've got a level 1 evidence now to say that all of these have been validated in that trial, where people with parotid metastases, 2 or more cervical lymph nodes, 3 or more axillary or groin metastases, patient with big metastases measuring more than 3 centimeters, any extracapsular extensions, positive margins at the time of the operation, recurrent nodal disease, or tumor spillage at the time of the nodal dissection. So this is the sort of thing that I would probably favor for patients to have a discussion with us and make a consideration for adjuvant radiotherapy following surgery. So a little bit of updates, I think, this talk will not be complete without me telling you to, a little bit of updates about the National Dermatology Radiation Oncology Registry. Now we've done this for over 2 years, and a bit of work, that has been done in Western Australia separately. So at 2 years, from the registry, it's been reported that for invasive disease, we have a local control over 85% at 2 years. And for in situ disease, being all those bounce disease and intraepithelial carcinoma, the 2 years reported outcomes has now been shown to be about 97% with the wide field technique VMAT spot radiotherapy. In Western Australia alone, being in Joondalup, Wembley, Fiona Stanley, Mandurah and Bunbury, 5 sites there. We have done over 190 cases over a year, and so far, obviously, we are still monitoring the outcomes, including the patient that I've shown you before. On the right-hand side of the screen, there's just a screenshot of a paper that was just published in the Journal of Drugs in Dermatology in February this year. The outcomes from the work that was done in America from a few centers across the Eastern Seaboard. They have reported about 99% of, or 98.9% of local control after 85 months with the use of superficial radiation machine. If you remember the picture I showed you before, and that's actually has been reported in this publication, except that this is actually a retrospective analysis, but as such, a big number of patients, over 1,000 there, with multiple non-melanoma skin cancer that's been treated with radiation since in these centers, and we have seen the outcomes to be reported to be that high. So we expect that with our radiation treatment, even in Western Australia, probably we'll be looking about 90% of local control. In summary, just to recap before we get to the next part of the talk today, which is probably more about the questions, when do you refer a patient to us? These are probably a good summary of all those indications. First of all, we're very proud to be able to afford to offer this extensive wide field cancerization treatment, either maybe on the scalp, the limbs, the torso, the trunk, even the face. Like my gentleman there, that's actually not suitable for more cuts. That would be a good example. Lesion at high risk of recurrence might be the lips, might be on the ear, or high risk features that I've already outlined before. Next indication would be tissue preservation concerns about optimal cosmetic outcomes from surgery. Usually would be on the face, where it's actually quite important, especially for those patients that obviously are a lot younger, and also for those patients that might be obviously working in the industries where you're facing customers and so on. Even more important for them to be considered for radiation treatment. Failure of after other therapies or inappropriate for surgeries, usually due to comorbidities. You can actually see radiation oncologists or radiation therapy instead. Sometimes patients who decline surgery, they want to go and have an excision done on the face, or come and see us. Perineal invasion, usually you see that in the report. But if you prior to surgery, they have already complained of sensory changes or any other neurological deficits in the area of the nerve, maybe raising concerns that could well be that the bigger nerves are involved. The next indication obviously will be, incompletely excised lesion, positive margins, where further re-excision might not be appropriate, and also for recurrent lesions where surgery might not be a suitable option for them. So in summary, these are all the times where we will be happy to see the patients in our clinic to talk about radiation options as a way to treat the skin cancer. So we move to the next slide there. Frequently asked questions. Before we get to this, I just want to confirm with, if there are any other questions, or just, these are the sort of questions that came to mind before when I was preparing the slides. Okay, do you have anything to add for now?
At the moment, no other questions have come through. So
we just
have any questions?
Just answer these questions now. Yeah.
Yes.
Okay. Right. So so hair loss. How about hair loss? So if you treat an area where obviously there's hair either on the face or near the scalp, or even on the limbs, obviously, for the dose of radiation treatment of about 45 to 50 gray, there is still a chance of the hair coming back. I was going to show you an example actually before, but I didn't get to actually get his photo uploaded onto the screen, where a man is actually, he had a bald patch on all his scalp. So he has his hair obviously like lots of other people with this similar hair condition, but he has this ponytail, I call it. It's actually this ponytail that's grown for over 20 years, and he didn't want to lose that. And he's got cancer all his scalp. So I told him, look, I'm going to do my best to actually keep that ponytail for him. And believe it or not, that was still there even about after 9 months of radiation. He actually has a similar appearance to those patients I've shown you already, but this ponytail is still there. So it's actually, we keep that away from radiation field. So how do we achieve that? That's when we go back to the earlier slides I've shown you before, where if you know what you're treating, you can actually tell the radiation planning software and radiation machines what you don't need to treat, including the hair. And you can actually outline that carefully, so you can actually prevent such thing from happening. And these are actually the benefits of using VMAT in treating skin cancer. So, but otherwise, if you end up, if patients have skin cancer all over the scalp, and they've got a bit of hair at the front here, you probably have seen that examples that probably will not actually be able to keep those hair follicles that actually sit in between sort of the skin lesions. The next question will be, can you radiate over the flap and a graph? Yes, the short answer is yes. I think this question will probably be more relevant to patients who've had skin graft, usually split skin graft, usually done by a plastic surgeon. It's very thin sort of layer of skin, usually taken from the area like the thigh, and come and be put in different parts of the face of the scalp. Have to be a bit more careful with split skin graft. We really want to make sure that it's already healed completely, because if you give a radiation to a skin graft that's not quite healed, there is a chance of that it might fail. So a patient might end up having to go for another skin graft. But if it's already been healed, like you've seen the example of my gentleman before, where he's already had a skin graft there and a skin graft there, and there's no problem whatsoever because it's all been done many months ago prior to radiation treatment. When you have a vascularized flap, usually from another area, that's even more resistant. more resilient to having those radiation. Often we don't see any flap sort of failing. All of these are taken into consideration when we do the treatment. The next question there, obviously we've answered that question. When should RT be used as adjunct to therapy? There's actually a website there. It's free of charge. Everyone can access that, including the public. It's called EVIQ, www.eviq.org.au, where it actually summarize the table that I've shown you before. You can actually obviously use that as a guide to knowing when to refer patient for adjuvant radiotherapy. Long-term efficacy of radiation therapy and control rates. We talked about that already in that paper that was actually from Roth and his colleagues and from America. I would say more than 90% for most BCCs and SCCs, and higher for the in situ disease. How do we avoid lymphedema when treating lymph with the FEMAT technique? I've shown you the example before. This is actually a special, very, very important consideration for me as a late effects radiation treatment when we treat the skin over the limb, either in the arms or in the legs, more importantly. So what we do normally, we would give them a treatment over 2 weeks. We would then give them a break for about 2 or 3 weeks after that. And then prior to resuming the rest of the treatment, usually another 3 weeks to go, we will actually review the swelling. So by giving them the break, the risk of lymphedema can actually be reduced significantly. And also at the same time, you might remember me showing you the planning for the treating the limbs before. We would actually spare about a third of the skin strip, where if you're treating the anterior part, which is the shin or round about that area, we're actually trying to spare the posterior part of the limb. And these will actually reduce the risk of lymphedema for most of those patients. The next question there is topicals versus radiation therapy versus surgery. I think some of you might have gone, and listened to the other webinar that was actually broadcasted from Sydney last week. If you did, if you haven't, there was actually a recording for that as well that you can actually access. The importance of a multi-modality or multidisciplinary teamwork when we treat skin cancer. In the ideal situation, a patient with skin cancer should be seeing a dermatologist, radiation oncologist, and plastic surgeon at the same time in a clinic. And I used to have this clinic that I used to remember doing this clinic when I was working in Wellington in New Zealand before, where we would do this clinic every fortnight, see about 20 patients, decide whichever way the patient should go. And that would probably be the best thing that would actually we can offer the patients. But in an environment like where we are now, where we have multiple cancer centers, multiple practitioners, it might not be as feasible to do that. But obviously, the collaboration between dermatologists, plastic surgeons, general practitioners, and radiation oncologists, and that's how actually we would be able to make the recommendation, the best recommendation for the patients. And last question that I have there, I think it did come up during a meeting that I did last year in Bunbury about the risk of secondary cancer from radiation treatment. Obviously, there's literature out there already. The rate is about 0.1% at 10 years, so 1 in 1,000. And the rate at 20 years is about 0.2%. So it's a very low risk, obviously, of secondary cancer induced by radiation treatment when we're treating, obviously, a cancer that is already at risk of metastasizing, spreading and having metastases elsewhere. Usually, this is sort of risk that we tell the patients, and most of them will be comfortable to accept that very, very, very small chance of having another problem from treatment. Right, I think that might be the last slide that that I need to talk about. Just to recap, recap, just showing you what we offer here. So we have, we built our treatment and our evidence. That's why we have the registry nationally. and we would actually treat the individual patients, according to what they come with. It might be, they have cancer in certain parts of the body. Obviously, that's the only area that needs to be treated. We would then follow them through for many years to come to make sure that they have achieved the local controls that they need. And obviously, we talk about free parking there. We have free parking at almost all sites except for Fiona Stanley. And also these exercise clinics that we have available at 3 of other Genesis Care sites. And for those patients that obviously live further away from the treatment center, we have accommodation available. In the north, we have the Two Rocks, and obviously in Bunbury, where I work as well. And obviously, you've got this Cancer Council accommodation available for them for free. And if we have the time, I might just show you this quick video about a patient experience, and then I'll open the floor or the sessions to any other remaining questions.
Sorry, Kasri, the volume of the audio for the video isn't coming through.
Oh, sorry. No, the audio is not there. Okay. Right, let me find a way to try. Yeah, looking at Kate. I don't know if I have a solution to that right now. So you can hear the video just now?
No, we can see the video,
No.
but we can't hear it.
You couldn't hear the audio bit of it, yeah. Look, what we might do, we might be able to share this video. I'll just send it across, with you, and we can perhaps share that with the rest of the attendees here. And I think that's probably what we could do. It's actually quite a good video to share his experience after having had radiation treatment, to what I've outlined today. So I might just stop that video, and I think that will be the last slide for the talk today, because the rest of the slides is just going to be talking about the NBROR. It's not quite ready for it's not it haven't got the full details that's actually required for this talk today yet.
Okay, no worries. So, well, I'd just like to thank you for joining us today. We greatly appreciate your time that you've put into the presentation and presenting for us. If there are no questions from anyone in the webinar at the moment, we will close it. Let me just double check. No questions seem to have come through. Okay, well, thank you very much, Kasri, for your time, and yep. I'll close off the webinar now.
Well, thank you everyone for listening, and hopefully we'll get to see each other in person one day through a normal seminar.
Possibly, I was hoping.
Yeah, I hope so too. All right, take care, and then stay safe, everyone.
Thank you. Bye.
All right, take care.